Hello, today I'm going to start by telling you a story that I think really sums up what an inborn error of metabolism is. So it starts in 1934 when a Norwegian woman had a lot of questions about her two kids. They were both intellectually impaired, developmentally delayed, and what she found really weird is that they had like a really weird smell and their urine had a really musty smell to it. Her thought was that these two things must be related, the developmental delays and the musty smell, and she went to various doctors trying to figure out whether they could help her. Finally, she found a metabolic specialist in Norway called Dr. Follung, who not only was a metabolic specialist, he was also something of a chemist, and he was really interested in trying to connect these dots. If nothing else, he thought, there must be a reason why this urine smells so weirdly, and he wanted to investigate that. So he got urine from the kids and he began testing it. He found out very quickly that this wasn't because of ketones, and he carried on testing it every single day for 2 months because he really couldn't figure out what was giving it the mousy smell. This is obviously not a man that gives up easily, or really at all, actually. Eventually, he thought he needs to start purifying and extracting compounds organically from the urine. And eventually, he found an abnormal compound in the urine that was phenylpyruvic acid. Okay, but Asborn Follung didn't just stop there. He wasn't just like, okay, now we have a reason why there's an unusual compound and we know why there's a smell. No, he went and investigated further. He went round all the institutions and hospitals in the area and ended up getting urine samples from 430 individuals that also had intellectual impairment. And in 8 of these samples out of the 430, he ended up finding this abnormal compound, the phenylpyruvic acid. When he went back to actually clinically examine these 8 individuals, he found that they had a lot of clinical similarities. So in addition to the intellectual impairment, a lot of them had really pale skin with eczema a lot of the time. And then they had like this stooping figure with broad shoulders and like a spastic gait. And then he took it another step and he looked through the family history of these individuals and concluded that this was probably inherited as an autosomal recessive trait. Dr. Follung published his findings and he gave this disease the term Imbecilitis phenylpyruvica, which, as you probably all guessed by now, has since become phenylketonuria. This was such a massive step in understanding inborn errors in metabolism. Understanding that one weird compound in the body is having all these other physical and physiological and mental effects. Since the 1930s, massive advances have been made in understanding all of this. The next big advancement was made by Dr. Jervis, who postulated that most likely the buildup of this compound was secondary to some abnormality in metabolism. He guessed that maybe there was an enzyme deficiency that resulted in abnormal compounds building up. And at about the same time, it was also shown that if individuals with this disease, phenylketonuria, reduce their phenylalanine intake, then they would do a lot better clinically. This was a huge step as well, that we didn't just have to give up to the disease, but there was something that we could do to at least improve it. In the 1960s, a Canadian pediatrician, Dr. Guthrie, had a son with intellectual impairment and a niece with PKU, and he kind of pivoted all his research interests to try to find a screening test for PKU. He did this super successfully, and that basically became the basis of the newborn screen that we have today. This PKU model has shed light on about 200 other inborn errors in metabolism. Just the fact that a buildup of a metabolic product could result in serious mental and physical impairments. Just that understanding. And then the understanding that that could be an enzyme missing. And then the understanding that we could screen for that enzyme missing. And then the further understanding that if that patient actually lacks that enzyme, then we have a treatment. We can give different types of foods to that patient to make sure that that metabolite doesn't build up. Hello, I'm Dr. Tala, and this is part 2 of the inborn errors of metabolism. So today we're going to go over 3 main points and I'll sum them up for you below. The first one is how inborn errors of metabolism present. So usually that's because the baby got a positive newborn screen test or with varied symptoms. And they can present with literally every type of symptom on the planet, whether it's skin, a rash, or whether it's neurological symptoms. But most commonly in the NICU, just like a lot of other things present, babies can have hypothermia, vomiting, poor feeds, tachypnea, lethargy, or neurological type symptoms, for example, seizures. Number 2, how should you evaluate inborn errors of metabolism? Just like everything in medicine, with a history, a good physical exam, and with labs. And I want you to get this point home. The most important labs to send are glucose, a gas to check for acidity, and an ammonia, and a bunch of other tests. And 3, how are inborn errors of a metabolism actually treated? Well, there's obviously an acute and a chronic treatment. Acutely, you don't want that abnormal substrate to build up any longer. So you need to stop building up any more abnormal substrate, and then you have to treat the baby acutely to get rid of the acidosis or the hyperglycemia and to get rid of any abnormal metabolites. So the first thing that you have to do is make the baby NPO, give IV fluids. So you don't want to give any proteins. So just dextrose and electrolytes if needed at about 100 to 150 mLs per kilo. Chronically, the treatment is going to depend on giving the baby or the patient different types of foods or formulas to make sure that that substrate doesn't build up again. And that's pretty much what we're going over today. So if you're done here, then remember to like this video. And if you write into us, remember to tell us where you're from. If you want a few more details, then watch on. Number 1, let's start with how inborn errors of metabolism are actually diagnosed. So like we already said, with loads and loads of different types of symptoms, or some of them are actually diagnosed by the newborn screen. So I just want to spend a couple of minutes talking about the newborn screen. Many countries have some version of the newborn screen, and even in the US, every state has slightly different newborn screens. Basically though, it's when a little bit of blood is taken from every single baby that's born, NICU or full-term baby, from the heel, so a little heel stick. That blood is sent to the state lab, and then the state tests it for a whole panel of different diseases, which are basically inherited. There's always a lot of conversation about which diseases should actually be on the newborn screen, but basically each state can decide that. And the diseases have to satisfy a few criteria. So first of all, it has to be a disease that can't be diagnosed by a physical exam. So there isn't a newborn screen for Down syndrome because you can diagnose Down syndrome nearly all of the time just on physical appearances. 2, the disease has to have a readily available test, which is not super expensive, because remember, you're doing it on every single baby born in the state. 3rd, the disease has to be serious that it's going to cause health problems early in life. So we wouldn't check for eczema, for example, which isn't necessarily a severe health problem, or we wouldn't check for like an increased risk of breast cancer because that isn't going to affect the child early in life. And 4th, it has to be a disease that if we do catch it early enough, there is a treatment or there is a way to prevent it that it will majorly change the outcomes for those infants. And this is probably the most key part of newborn screening. So for example, checking for hypothyroidism is a great example of a perfect test for the newborn screen. It's easy to pick up, and if you do actually catch the hypothyroidism, you can give replacement thyroid hormone to the babies, and those babies will then be unaffected. If you miss them and they don't get the replacement thyroid hormone, then it can lead to severe developmental disability. In every country, a state organization kind of determines which sort of tests should be on the screening panel. Obviously, in different states, especially in different countries, there's going to be a slightly different combination of genes, and some diseases are going to be more common than others. Currently, there are 29 recommended inborn errors of metabolism to be tested on the newborn screen. As you all probably know, PKU, so phenylketonuria, methylmalonic acidemia, and propionic acidemia, all pretty common inborn errors of metabolism, are all on that screen. I just want to say 2 more things about newborn screens. The first one is by definition, they are screening tests. And by definition, screening tests, you want to pick up every single person with a disease. So that also means that you're going to end up with a lot of false positives. So a lot of people that it says that they have the disease, but they don't really. All I can say is that you have to assume that this is like a Peter cried wolf situation. Assume that every single one is a true positive and follow it up accordingly, because otherwise you will end up missing some true positives. And the second thing I'll say is that the newborn screen can sometimes take a week or two to come back, and some of these diseases can present before the newborn screen comes back. So don't assume that the baby doesn't have it because it's on the newborn screen. Okay, so maybe you diagnosed the infant as having an inborn error of metabolism because there was a positive newborn screen. Or how else could the baby present? So the first thing that you should realize is that the placenta works as a really good dialysis machine in utero. So even if an infant lacks an enzyme in utero, the placenta is really good at clearing the excess metabolites and giving the baby what it wants. So inborn errors of metabolism rarely present before the baby is actually born. But we're in medicine, so there are always exceptions. So sometimes the placenta can't do enough and the baby will present with hydrops. So examples of this are Niemann-Pick disease as well as Gaucher disease. Or the baby could be born with abnormal facial features, for example, Zellweger syndrome or Hunter's disease. If the babies present after they're born, then they can have more of an acute metabolic crisis type presentation or more kind of chronic abnormalities. I'm going to emphasize more of the acute metabolic crisis right now, because that's what you might end up seeing in the NICU or the newborn nursery in the first few days of life. So these are kind of the symptoms that they can present with. So A, vomiting or just failure to feed. Obviously, this is often because they're just not tolerating the formula or they don't have enough energy. They're just so low on glucose that they don't have the energy to feed. B, lethargy or just extreme tiredness. So often this can be from a build-up of metabolites, for example, ammonia, or again, it could be that they just don't have the energy to be able to move and function. C, the baby may be taking rapid, deep breaths. And really there are two reasons for this. So the first one is that the baby could have a metabolic acidosis. And if you remember, what does the body try to do when there's a metabolic acidosis? It wants to balance out the pH by causing a respiratory alkalosis. So what the body's trying to do is blow off all the carbon dioxide, so there is a respiratory alkalosis. So the baby might be breathing rapidly to blow off that CO2. Another reason why a baby might be breathing rapidly is just a high ammonia level. If ammonia gets really high, then the babies are just comatose. But if it gets to kind of like 150, 200-ish, then it acts as a central respiratory stimulant and just makes the baby breathe deeper and faster. That's often a really abnormal finding to have, especially if the baby doesn't have metabolic acidosis. So let that kind of set off your spidey sense. I just saw that movie. If there's like a low CO2 with no acidosis in a kind of slightly abnormally acting baby. D, hypothermia. Ammonia in itself can cause this, but also just lacking all energy. You all know that babies can become hypothermic or cold. E, like we said, neurological symptoms. So hypotonia, floppiness, sleepiness, lethargy, seizures. Again, most of the time this is a buildup of toxic metabolites. F, liver failure. So like a high direct bili, high LFTs, maybe a coagulopathy. And G, going back to the whole PKU thing, is that the baby may have just a really abnormal smell. So you've all heard maple syrup urine disease, where the urine smells like maple syrup. In tyrosinemia, the babies smell like sulfur. With PKU, like we were saying, the babies might have like a really mousy smell. And then you've all heard of sweaty feet smell or isovaleric acidemia. As an aside, I've never smelt any of these, even though I have had a couple of babies with maple syrup urine disease. But I will say that I have worked with nurses that can like tell you exactly what bug the infant has based on the smell. So if somebody ever tells you that a baby has a really weird smell, then take it very seriously. So just to reiterate, based on all those symptoms, if you're not really thinking about it, with all of that range of symptoms, you'd really just assume that the baby was septic. So always be thinking about IEMs. Like we also said, IEMs can present with just about every organ and system going wrong. But generally, you'll have a little more time to actually make that diagnosis rather than the acute metabolic compensation where you have to be thinking about it, otherwise the baby's not going to make it. And obviously, if a baby does present with something a bit weird like hepatomegaly or a cardiomyopathy, that in itself is weird enough for you to think, okay, what is going on here? Is this an inborn error of metabolism? And you'll kind of probably start going down that pathway. Another way to say all of this is that if you're ever on an exam and they present you with literally any symptom and they say, could this be an inborn error of metabolism? The answer is yes. Yes, it could be. Okay, moving on to number 2. What sort of evaluation should you do for inborn errors of metabolism? Like we've already said, we always start with a good history. As we've said, a lot of these diseases are inherited in an autosomal recessive fashion. So it's always important to ask if the parents are in any way related. Obviously, this has to be done in a really delicate way. And so I'll say something like this, that a lot of these diseases are inherited and they're genetic. So I have to ask this question, are either of you even very distantly related in any way, and just kind of play the whole thing down. Also, you should find out whether within their families there have been a lot of unexplained pregnancy losses or stillbirths or unexplained childhood deaths. A lot of people do genetic testing even before they get pregnant, so ask whether they had any genetic testing done. The next thing that you should do is a good physical exam. I'm not going to go over the details of that because, like we already talked about, every organ and system can be involved and you should be covering everything in the body. So just do the best physical exam ever. So now let's go over the tests that you should order, and I really feel like I've been a broken record here. But again, I'll say it. Make sure that you get a gas, checking for acidity, so specifically metabolic acidosis most of the time. You can also get respiratory alkalosis from the gas, which we said you can get with high ammonia levels. So you get a gas, you get a sugar, checking for hypoglycemia, and you check an ammonia level. These aren't just important tests for diagnosis, but these tests are so crucial because if any of them are extremely abnormal, so like a really high ammonia level, a lot of metabolic acidosis, or no sugar, all of them can be lethal. So immediately you'll know that you have to correct these labs. Then obviously you're getting a whole bunch of other labs. So you'll be getting a CBC, and anyway, a lot of these do present like sepsis, so you're probably getting a CBC anyway. But some IEMs, specifically the organic acidemias, can also present with thrombocytopenia and neutropenia. You'll want to get electrolytes because that can help you decide whether the baby has an elevated anion gap or not, and add other information as well. Liver function tests, so AST, ALT, direct billing and everything, because obviously some IEMs affect the liver. Galactosemia, which is a disease where babies cannot break down lactose, is the disease that affects the liver most commonly. So what you're also testing for is galactosemia. Just as an aside, these infants can present not just with liver function abnormalities, but also they're at increased risk of getting E. coli sepsis. So galactosemia, LFTs, can't break down lactose, E. coli sepsis. These are such common board questions, so remember all of that. A lactate level, which could kind of help determine what type of acidosis that you have. Then you start getting into slightly more specialized tests. For example, plasma amino acids, urine organic acids, a carnitine level, or specific tests that need to be done in the urine. Then, depending on all these results, the metabolic specialist will ask for exactly which test that they want to order next so that they can diagnose exactly which disease the patient has. Like, not just an organic acidemia, not just a urea cycle defect, but exactly where the enzyme is lacking or what the issue is. I'm not going to go over these, I don't know them, and neither do you need to know them. So what you do need to know is to call a metabolic specialist and take their recommendations seriously. 3, now let's talk about the management of inborn errors of metabolism. So like we keep saying, the first thing that you have to do is prevent further buildup of toxic metabolites. So you have to assume that maybe they can't digest protein, or maybe they can't digest lactose for galactosemia. So you want to stop the formula or the breast milk that the baby has been getting. That's the first thing that you do, make the baby NPO. Then you should start fluid resuscitation. So start the baby on dextrose of like D10 at like 140 to 150 mLs per kilo. Add electrolytes as the baby needs. If the baby becomes very hyperglycemic, then you might want to add insulin. Just try to put the baby in more of an anabolic state. Feeds or total parenteral nutrition, where you're giving the fat and the protein and everything directly into the blood, shouldn't be started until you've actually spoken with a metabolic specialist and they've let you know exactly what the baby can tolerate. If the ammonia level is high, then you have to bring that down, because a super high ammonia level can be lethal. Really, anything above 100 is high, but most babies won't start having symptoms until it's closer to above 150 or 200. If the ammonia is above 200 micromoles per liter, then it needs to be actively brought down with ammonia scavengers. Examples of these are sodium benzoate and sodium phenylbutyrate. If the infant also has a urea cycle defect, then the baby may also benefit from actually administering citrulline or arginine. Again, all of this is done under the guidance of a metabolic specialist. And if the ammonia level is above 500 or above 300 with symptoms, which is pretty common, then the baby may actually need dialysis to try to get that ammonia out of the body. So now let's move on to the acidity. If the baby is really acidotic, then you do want to replace with bicarb. This is kind of quite different from elsewhere in neonatology, where we've really moved away from actually giving bicarb. But in these situations, if the baby does have a metabolic acidosis or the bicarb level in the electrolyte is less than 14, then you do want to replace with sodium bicarbonate, normally 1 to 2 milliequivalents per kilo. Then hopefully you'll be able to bring the baby back and the baby starts improving slowly, and you'll be able to start reintroducing feeds. Obviously you need to be following labs very closely as well. There are thousands or maybe hundreds of different formulas which are specialized for infants that have metabolic abnormalities. For example, in infants with galactosemia who can't tolerate lactose, we end up putting them on a soy formula because the commonly available soy formulas also don't have lactose in them. So for example, we'd give them Prosobi or Isomil if they have galactosemia. Then there are other specialized formulas for infants with, for example, protein issues. So for example, a formula called Periflex is for babies with PKU. And that formula doesn't have any phenylalanine in it, which obviously is important because infants with PKU are unable to break down the phenylalanine. If infants need steady feeds, then they may end up going home with gavage tubes or even needing a surgically placed gastric tube. This can be for babies that can't afford to not have a steady stream of feeds always going, because they're completely incapable of breaking down the fatty acids or the protein when they really need it. And then a whole bunch of inborn errors of metabolism have super specific and very advanced forms of therapy. So for example, there's enzyme therapy for some diseases, there's gene therapy for some diseases. Some diseases benefit from actually doing a bone marrow transplant as well. There's obviously a lot more to cover that's kind of beyond the scope of all of this. Realize just again to recognize the acute metabolic crisis and to get help from your friendly metabolic specialist sooner rather than later. So we got through IEMs. If you learned anything from this video, then please press like and write to us and tell us where you're from. If you're interested in neonatal education, then please subscribe to the channel. We are so thankful that you are here and we're building this community together. Thank you so much.